Welcome, welcome, everyone. Thank you so much for being with us on this rainy Wednesday. This is the second of our community conversation series that the Racial Equity Task Force has committed to holding. And I do just want to give a special shout out. We have myself, we have Naika Thompson. We also have Sarah Smith and Yamina Penn on the line as our Equity Task Force members. Please definitely, I'll put the link in the chat just to give you somewhere to go in case you want any more information about all of the great work that we're doing. But one of our commitments that we have is to hold these monthly conversations. So this is our second one. We have quite the treat for you. We have a room full of Black girl magic here tonight, y'all, to educate you around racial disparities, with a special focus on women's health in honor of Women's Month. So I do just want to give a really brief overview of everyone that we have here tonight. We have Dr. Tara Moulds, who is a generalist OBGYN at Brigham and Women's Hospital. She also teaches at Harvard School of Medicine. She is originally from Kingston, Jamaica, and she moved to New England to attend Wesleyan University. Tara lived right here in Farmington while attending UConn School of Medicine. She then moved to Massachusetts after graduation, where she completed her residency at the University of Massachusetts School of Medicine. Her professional interests include minimally invasive gynecologic surgery, racial and ethnic disparities in women's health, and increasing diversity in medicine, and of course, delivering babies. Next, we have Corinne Prescott. She is a mother of 3 beautiful Black babies, Jaden, Johnny, and Jordan. She is a social activist, advocate, and organizer, entrepreneur, author, a LaSalle University alum with a degree in psychology, and a proud Black woman. She is outspoken, smart, and a powerful public speaker. She is a survivor. She is a warrior. She is open, transparent, raw, and at times uncensored. And Corinne is white supremacy's worst nightmare. We also have attorney Nichelle Mullins, who has served as the president and CEO of Charter Oak Health Center, Inc. since 2015. Charter Oak Health is a federally qualified health center that provides quality comprehensive health care to the underserved. Attorney Mullins has served in various professional capacities over the course of her career, working to improve the lives of individuals through the legal system and direct service. She is an attorney, former business and ethics professor, and an ordained minister. She is a native of Hartford and is happily married to the Honorable Raheem L. Mullins Sr., Associate Justice of Connecticut Supreme Court. And she also has 3 beautiful children, Tatiana, Nia, and Raheem Jr. We also have Dr. Camelia Lawrence. She is a board-certified surgeon specialized in benign and malignant breast disease. She has fellowship training in advanced breast cancer surgery, including skin and nipple-sparing mastectomy, sentinel node biopsy, and oncoplastic techniques. Now, you guys are the professionals here, so I apologize if I butcher any of these procedures. She earned her bachelor's degree from Fordham University and her medical degree from the University of Rochester School of Medicine. She completed her residency at New York Medical College and then entered her fellowship training in breast surgical oncology at the John Wayne Cancer Institute in Santa Monica, California. She currently serves as the director of breast surgery for the Hospital of Central Connecticut and Midstate Medical Center, responsible for furthering developing their breast programs. She also serves as assistant professor of surgery at the University of Connecticut School of Medicine. She advocates for women's health, especially breast cancer care, in speaking engagements, TV interviews, articles, presentations, and involvement with Susan G. Komen, New England, for which she served as the vice president of its board of directors until January 2021. Dr. Lawrence volunteers her time and knowledge to support numerous organizations throughout the state, including the board of directors for the Women's Medical Association of Fairfield County and the Community Foundation of Greater New Britain. And last but certainly not least, we have our moderator that we are so excited to have with us again, Miss Mercy Adekola. She is a senior at high school, and at Farmington High School, I apologize. And when I tell you that our youth are leading the way, She is definitely leading the way. A recent Moorhead Kane Scholar. She is the president of the Multicultural Student Union, as well as a representative on the Social Justice Council based at FHS. Her activism centers around racial equity and pro-Blackness, but with a strong emphasis on intersectionality between minorities. She's given numerous social justice presentations and partaken in many different conversations surrounding Black feminism, environmental racism, affirmative action, microaggressions, white privilege, and fragility. And we're in for a special treat because, you guys, one of her passions is public health. So I'm so excited to get us started. I do believe we're going to do one of our giveaways, right, before we really jump right in, and then we'll go ahead and get talking. Or shall we start the panel? Oh, there we go. So some of you guys who were on last time, we really enjoyed the the click to spin the wheel. So let's go ahead and see who we have. Oh, we have Ed. Ed, I don't think you count. We have to spin again. Ed, I didn't even see your name. I apologize. He is also one of our task force members. Let's go ahead and try and spin again. But thank you for being here still, Ed. Okay, we have Meredith Young. Thank you so much for being here, Meredith. And sorry, I neglected to mention what our fantastic giveaways are for. We have Black Made Sense. So we have gift cards for candles from a Black-owned company. We have Sweet Equations. We have gift cards. That is actually a Farmington-based, Black-owned company. We also have a gift basket for From the Talented Clothing Company, which is also Farmington-based and Black-owned. And then Nancy, keep me honest, I think we have someone else, correct? Well, let's go ahead and see let's do that again. Let's go ahead and get another giveaway. We have Catherine Farah, fantastic. Well, thank you to everyone for being here. We will have more giveaways as the program proceeds, but let's go ahead and get started because we have a lot of great information to get you this evening.
So hello, everyone. Like Jess said, my name is Mercy Adekola. And before we start with our panelists, we have a representative from the Reese Center here to speak with us. This webinar is in partnership with the Reese Center, which stands for the Race and Equity in Education, which works to make transformative change towards racially just schools and communities. They envision an equitable and just world where all youth have what they need to grow and to thrive. We envision empowered students supported by cautious, critically thinking adults and supportive, safe schools and communities. And they work together towards a world in which equity is institutionalized in all school systems. I'm excited to introduce Andrea Hawkins, who has officially started working with the Reese Center on November 16th. And she's here to give us a brief introduction on the historical healthcare inequalities that face America.
All right, thank you so much, Mercy. Good to see you again. Good to see everyone tuned in today. Fantastic. As Mercy mentioned, I am the interim executive director at Reese Center. We are in the process of looking for our new executive director, and until we do have that new executive director in place, I am holding down the fort, helping us just make sure we continue to do the great work at Reese Center. I'm going to share my screen. I have quick little presentation for us to go through, because I know you're going to hear from some fantastic people. It's always better to hear from folks who are in the trenches, living and breathing this every single day. So I just want to make sure we give enough time to get questions and hear from our fantastic panelists. I can't wait to hear from them. So we talked about this being Women's Month, and I don't know that we really said that specifically, but we're here celebrating March and thinking about women and thinking about women's health. And we have to think about that every day at Recenter, right? Because our children eventually become these women and become adult women. And it's an important part of their own development. So I want to just share a little bit, give a little bit of a foundation that I'm hoping will support the other things you'll hear from the panelists today. But before we jump into this, let's talk a little bit about Recenter and how it was founded. So back in 1992, Paul Newman and Joanne Woodward helped us create the Discovery Center. And the Discovery Center was more focused on diversity, equity, and inclusion concerns. And what they were primarily trying to do was find ways to bring children who were in the suburbs, primarily white, and children who were in urban settings, primarily people of color, bring them together and help in these early formative years develop ways to appreciate each other and work together. And that was the initial foundation of the Discovery Center. And over time, there was a need, there was this identified need to really focus more on being intentional about improving race equity. And I'm going to share a little bit of information for you about why this is ever so important, this idea of continuing race equity. So that's what we do at Recenter. We're making sure that there is justice and empowerment in this educational experience of all people, and especially our students in K through 12 environments. So what do we do at Recenter? We do a lot of things, but primarily what we're doing is working with teachers, working with administrators, working with people who work with our children in the K through 12 school environments, and making sure that they are culturally competent, have the information that they need to show up in a way that honors every single student in their classroom, regardless of race or gender or other identities. So we offer professional development. We do some coaching around race equity. We do consulting. There might be specific projects that we might do from a race equity standpoint. And then we will do whatever is needed in terms of providing services to really affect systemic change when we think about race equity in the school systems. So that is why we exist. That is what we do. I love that Mercy read our mission. She read our vision. So you have a sense for why we exist. And then you can see our values here, right? So equity and justice is important to us. Learning and growth, communication, relationships, and community. And when we say community, we mean in our school systems, everyone working together. Excellence, optimism, and impact. These are all really important values that we think about and work with every single day at Recenter. But why are we here today? Today we're here to talk a little bit about health disparities, and how that shows up, especially for women. So we can't really have that conversation without talking about the social determinants of health, right? So these are those factors that are going to determine what each person's health outcomes are going to be. And they are influenced by these 6 areas. We'll get into them a little bit more, but these 6 areas of focus, right? So economic stability, social and community context, neighborhood and environment, healthcare, education, food. We'll talk more about what each one of these are, but these are the things that decide what our health outcomes are going to be. So let's jump into it. So let's look at economic stability first. So think about your health status in terms of whether or not you have employment, your income level, what expenses you're managing or debt that you may have that you're dealing with, medical bills, which I'm sure is part of the debt if you're carrying debt. in support, like what kind of supports do you have? So when we talk about economic stability, that's what we mean. Neighborhood and physical environment. So, right, this is where do you live and what is that like? What is your housing like? You know, do you live in a community? I know I mentioned for the folks that were on the call last month when we did this talk, and we were talking about equity in terms of communities. And I mentioned that, you know, I grew up in the projects. There was a lot of noise every day, every night. I wouldn't say that I often had a solid sleep night without hearing neighbors making noise, or, you know, just so much commotion going on in the community. And some children live with that reality, right? So that safety, playgrounds, parks, can you walk around? What is your zip code? What's your geography? And there's a lot of data that shows, you know, health outcomes are related to the zip code that you live in. Moving on to education, and we'll dive into this one a little bit more once we get through these. But literacy, do you understand? When I think about us all having to get vaccinations, I don't know about you all, but, and this is not a knock, if there's anybody here from the state agency that put this together, this is no offense. But I have a master's degree, and it was really hard for me to figure out how to sign up for my vaccination. How do people that are, you know, don't have literacy levels that help them through that process get a vaccination and do that well? Like, this is really an important right point around this education. Early childhood education, right? These early interventions are so important. Vocational training, having some sort of trade training. And then higher education, some level of, you know, an associate's degree or bachelor's or higher master's. Moving on to food, right? Do we have access to healthy options? We hear this term food desert, and these are typically in urban areas where they can't get access. Folks can't get access to healthy food. The things that they get access to are like McDonald's or chips and soda, and things are just not going to create healthy outcomes. So what is your food access? Are you hungry? Are you able to eat every day? That's going to determine. Community and social context. So are you connected? Are there people that are concerned about you? Are you facing discrimination? Are you living with daily stress? These are all factors in terms of our health outcomes. And then don't get me going, because we could stay on this healthcare system and all the ways that it is broken and needs all types of interventions to make better outcomes for all of us, regardless of race, age, no matter what. But there is a direct connection in terms of our quality of care, whether or not we can get access to the providers that we need. I had an issue with, I had a skin issue, and it took me, I'm not kidding you, 6 months to get a dermatologist appointment. How can you have a good health outcome when you're waiting 6 months to see a doctor for something? And then just making sure this provider linguistic and cultural competency. I mean, this is what we're talking about as well, right? Sometimes we've had experiences with healthcare professionals, and you know, that they may talk above what you can understand, and they're not trying to figure out how to make sure what they're sharing with you is understandable. So all of these things that we've talked about, and when we talk about health outcomes down here at the bottom, you can see, you know, we're talking about all types of health outcomes. And these all play into our health and our health outcomes. So diving in a little bit deeper, and when we think about at Recenter, when we think about addressing racism, we know that racism negatively affects our health and creates stress, right? And it includes this bias related to stereotyping and prejudice and discrimination and oppression. There is oppression when you think about racism, right? And there's some ideas, well, how do we start to address this? Well, let's think about multicultural teaching. Let's make sure that we're broadening out. I love that in the state of Connecticut, we're looking at including African American and Latinx education in our curriculum. I know initially it's not going to be mandatory, but I'm glad that we're starting to move in that direction, and eventually it will be, because that's important for everyone to sort of understand from various perspectives. And then at the institutional level, making sure that our school systems reflect different people of color and different, genders and so forth in the staff and faculty, so that there's a better chance at us having more race equity in our interactions, and making sure, that each child has that best opportunity to be their best self in their learning. This was amazing to me, and some of you may already know this metric, so I'm going to share it. But did you know that African American girls don't misbehave more or commit more serious infractions, but they still receive more severe penalties for the same behavior as their white peers? Nearly 6 times more likely to get an out-of-school suspension. And if a child is out of school, they're not learning. And if they're not learning, what are they doing, right? Are they in situations that are putting themselves in danger, getting in trouble with the legal systems, whatever it is? So how do we keep our kids in school and make sure they're having an equal chance to learn? But nearly 6 times more, they're getting out of school suspension more than their white counterparts. And so that is something that we are looking to address in the work that we're doing, and making sure that all of our kids have an equal chance to learn and to thrive, and to really live out their best possible life and reach their full potential. Teachers need these skills. Teachers need to show up culturally competent, so that when there are issues that surface, they are prepared and they are treating these children in a just way, in a fair way, and helping them reach their full potential. Every student should feel supported. We endeavor to completely eliminate racism in the classroom and in our communities. And that is why ReCenter is here. And that is why we do our really important work every single day. And I'm happy to take a question if there are any questions.
Well, just in case there are questions, thank you so much, Andrea. We appreciate the foundation. And as always, if anybody has any questions that come up, please feel free to put them in the chat, or you can raise your hand and you can ask it in person. We love to hear voices and see faces. I did want to take a step back because it's super important to make sure that I properly shout out all of our sponsors for tonight. So I just want to take a step back and make sure we know. So we have the Key Bookstore, which is located in Hartford, Connecticut. They have donated gift cards. They're providing gift cards. We also have Black Made Sense, which is a Black-owned Kindle company based in Avon, where we're also going to be giving away gift cards from them. And then we have Sweet Equation, which is also a Black-owned Farmington. And then we have a donation for the Talented Clothing Company. So I just wanted to make sure, because we are so appreciative. And I will also be putting the links to these businesses in the chat in case you are not a lucky winner tonight, but you still would like to check out these businesses. With that being said, Mercy, do you want to go ahead and bring us to a couple more giveaways before we dive right in?
I can. So we'll pull up the wheel for you guys. And we're going to do 2 more giveaways before we get into our lovely panel discussion. So let's see who the winner is. Yamani Penn, congratulations. And then
we actually have to do that again because Yamin is one of our equity task force members.
Oh. Okay, 2 more, I guess. Let's. Stephen Smith, congratulations.
Yes.
Nicole Kodak. Congratulations to our 2 giveaway winners. And we have a couple more giveaways to do throughout the discussion. So if you haven't won yet, don't give up hope. So now we're gonna get into our discussion with our lovely panelists. Hello. So as it said before, I'm Mercy Adekola, and we have all our panelists here. Would you guys like to introduce yourselves really quickly? Just say your name so everyone can see your faces on the screen.
Hi, I'm Nichelle Mullins. Thank you for having me. I'm excited about the conversation.
Hi, good evening. I'm Dr. Camelia Lawrence. I'm excited about the discussion ahead. I am a breast surgeon with Hartford Healthcare.
And I'm Tara Mold. I'm currently an OBGYN at Brigham and Women's Hospital in Boston, and I teach at Harvard Medical School, and I'm very excited also about the conversation.
Hi, I am Corinne Prescott, and I am extremely happy to be here, and I'm looking forward to diving right in.
Perfect. So let's do just that. I'm gonna, well, first of all, I'd like to say thank you to you all for being here today. You guys are the representation that we need in our Farmington community for strong, powerful Black women. And I'm super excited as well for this conversation. And like y'all said, let's dive right in. My first question to you guys that I guess that I'll address to Dr. Lawrence, but anybody else can jump in and add in after for the same question. So what are some of the biggest threats to health equity that you are seeing amongst your patients and in the healthcare industry in general?
I can speak to that as it pertains to breast cancer. Breast cancer is the most commonly diagnosed cancer among women. Each year in the United States alone, about 250 to 275,000 women are diagnosed. And I often say it is very difficult to find somebody who does not know someone who's been impacted by breast cancer. We're all susceptible. We all know somebody who has had to deal with the disease or a family member. As it pertains to breast cancer among women of color, we have a higher mortality when compared to our white counterparts. So women of color are almost twice as likely to die of their breast cancer diagnosis. And there are a multitude of factors that contribute to this, some of which were discussed in terms of the social determinants of health. However, some of the factors include late-stage diagnosis. A part of it has to do with the biology of the tumor as well, and also access to treatment and access to culturally competent quality care for the diagnosed cancer.
Thank you for sharing. And we're definitely going to expand more on some of those factors, especially as it pertains to breast cancer. But I'd like to open up the same question to our other panelists. What are some of the biggest threats that you see to health equity across the board, not only amongst your patients, but in your own communities?
Oh, sorry. Do you want to go, Doctor?
No, go ahead.
So I am an activist and I am on the front lines daily. And one of the things that we noticed recently, Better Manchester put out an article talking about how COVID is affecting the Black and Brown community in Manchester. More specifically, the Latina, Latinx, Latino community, the Hispanic community, more so even than the Brown community. And I think that is because we do have a large number of undocumented folks here in this town, as there are throughout the state. And so because they're undocumented, even though there are health centers where they can go, a lot of times they are afraid. They're afraid of being deported. And so they are not getting the vaccine. They can't, but they're also not going to be able to access, they're afraid to access just regular checkups. well visits, physicals. And so as a result of that, we're going to see not just undocumented folks, but even poor people, just Black and brown people who are the working poor, not necessarily get the health care that they need for a variety of reasons. A lot of times it's not accessible to them. They may work several jobs. They don't take off for themselves. They don't have the PTO. They have to save it for a sick child. So, so in the community that I'm in, which is all over the state, I am seeing a lot of Black women more and more, because of the stress that they are under, be diagnosed, like myself, with autoimmune diseases. I have multiple sclerosis. So that's, that's what I'm seeing. And a lot of hypertension, high blood pressure, a lot of heart disease. And trauma is real in the Black community and brown community, and it can even be genetic. A lot of the things that take place. So, yeah.
No, thank you for sharing. Thank you for sharing. So if no one wants to add to that question, I guess we can kind of move right on. And
I can add something.
Oh, perfect.
I just wanted to echo both Dr. Lawrence and Karen's comments. I've seen COVID highlight and exacerbate the social determinants of health in underserved communities and communities of color. And so now people who did not feel comfortable acknowledging that social determinants of health existed prior to COVID have no choice but to acknowledge them now. And you hear people, a lot of different towns, even our state legislature, declaring racism as a public health crisis. So people are having these conversations, but many of us know that we've been having these conversations for far too long. And so what I've seen is now people are comfortable having the conversations, but they're not necessarily comfortable doing something to change all of these inequities that we see. It has become increasingly frustrating to work in a community health center, because when you work in a federally qualified health center, you do much more than just provide health care. You provide access to other community-based organizations that can provide access to transportation and food and clothing and housing. So you get to see a lot of what the other two panelists have already discussed. And it gets really frustrating, because the resources are there, but they're not really trickling down to the communities that need them. And so I'll leave that right there. I'm sure we'll discuss it in more detail as we move through the conversation.
Yeah, I would just reiterate that. And I think the other thing is, even if you can access care, access to culturally competent care with somebody that you feel comfortable with being honest with is difficult, no matter where you are in America right now.
Thank you all for sharing some insights, and you guys definitely did a lot of bouncing off each other, which was great. Something that I want to punctuate, and maybe we can expand off of that as we go on, is the conversation of trauma and generational trauma. And since we're talking about it's Women's History Month, generational trauma and trauma with Black women. And as Black women in your fields, what are, of course, if you're comfortable, some of those instances of discrimination and racism in the healthcare field, and not only the healthcare field, but in your identity as a Black woman, and how has those experiences changed the ways in which you viewed the communities that you exist in?
Can I please tackle this first? Because I come from a different place, I almost feel unqualified to be amongst the rest of these panelists. You all are amazing. Aunt Mercy, you're amazing. And so I am basically a case study for what trauma does. When I was diagnosed with MS, the first therapist that I had, which dealt with medical trauma, said that not all, let me see if I can get this right, not all patients who have autoimmune disease experience trauma, but all of his patients who experience trauma all have autoimmune diseases. And so one of the things that I truly believe is that the trauma becomes, and this is not any research, this is just me living with this daily and being on the front lines and doing the work. I only have a little old bachelor's degree in psychology. So don't take my word. This is just my opinion. I believe that when you experience such a heavy load of trauma, so I was molested at 7, I was raped at the age 18. I was raped again in my marriage when I got divorced in 2018. I was raped in my second marriage. And so, but prior to all of that, I was diagnosed in 2013 with MS. And what I believe is that all the things that I experienced as a child, 7 years old, 18 years old, the brain can no longer handle what is happening. The PTSD, the anxiety, the depression. And so it has to manifest itself in some other way. It has to spill out in some other way. And so me personally, I believe that's where a lot of the hypertension comes from. That's where the autoimmune diseases come from. That's where the heart disease comes from, the risk for stroke, for TIAs. And so when we talk about, you know, me as a Black woman and racism in healthcare, when I had to switch my original neurologist, a white man who had MS. And so, you know, we know a lot of the drugs out there are tested on older white men. And so an older white man doesn't have the same genetic makeup as a younger Black woman. And so because he was doing so great, making $1 million, and here I am, a single woman, just lost my job because of how sick I was, and I'm on cash assistance and SNAP, he is trying to basically say that I should be where he is. And so when I would try to explain to him my pain, and what I would try to explain to other doctors my pain, time and time again, they refer me to psych. In fact, I was actually admitted involuntarily to a psych ward because of how I kept trying to express the pain that I was having with MS. And they kept saying, there's no, MS doesn't come with pain. But when I talk to white folk who have MS, I hear repeatedly about the pain, and the same pain that I was complaining of, the same anxieties that panic attacks, they're getting prescribed, you know, opioids and Xanax, and I'm getting Motrin and a ticket to the psych ward. So I am the poster child. I am the case study of what racism and healthcare in this country and white supremacy has done, not just to me, but it's generational. Vicarious trauma. My daughters see what I'm going through, but I'm hoping to change that by being on panels like this and by being on the front lines daily, so I can I can break that generational curse.
Thank you so much, Ms. Prescott, for sharing. I appreciate everything that you said, and you existing and living in spaces like this is a testimony to how far you've come. And I'm thankful that I get to talk and speak with you today. So thank you for being here. I appreciate that. And if nobody wants to add on to that question or elaborate on that, we can definitely move on. And the next topic, and we'll definitely be cycling back to trauma and how the effect that trauma plays on Black women in healthcare. But I also want to ask about implicit bias, and especially implicit bias amongst clinicians and doctors and nurses. And so my question is, how does the implicit bias in the healthcare industry, otherwise known as the unconscious preconceived notions that people have surrounding other groups of people, how does these implicit biases have explicit effects on the healthcare outcomes, specifically for Black people?
I can speak a little bit to that. I think as patients of color navigate in the healthcare system, you will definitely come across unconscious biases, and they definitely have negative ramifications for patients. The assumption that a patient doesn't understand exactly what's going on We've had similar cases where the pain within a patient complains of is appreciated differently for different subgroups. I can talk about breast cancer in particular. There was when I was in the greater New York area, there were patients who had breast cancer, had surgery, and needed the radiation. And as you know, breast cancer, the management of the patient is a multidisciplinary approach, and surgery is just part of the algorithm. So for you to be effectively treated, you have to complete the entire care continuum, which is sometimes chemotherapy plus radiation. And there were women of color who were not going on to their radiation. There was a preconceived notion that they would be non-compliant with the radiation because they had difficulty getting in for their routine, just a surgical appointment, or the chemotherapy and radiation is every single day, usually on average 4 to 6 weeks. However, without the radiation, you don't get the consolidated full treatment that you need, which affects your overall survival from the disease. And I think that there were some clinicians who thought that they were actually doing the patient a favor by not adding that additional every day for 6 weeks. But we know that that abbreviation of the treatment has long-term implication in terms of overall survival. I think when, there was a study recently and I think it was in Stanford, looking at Black male patients with prostate cancer who were assigned to Black male physician versus those who were assigned to non-Black male physician. And it was very clear that there was more adherence in terms of recommendation. I think it has a lot to do with trust as well. But there was more shared decision-making. And all of those factors combined, I think, impact how a patient will do in the long term. And we deal with bias sometimes. Sometimes it's in the form of microaggressions, and sometimes it's macroaggression. As a patient, sometimes I think you may feel as if you're in a vulnerable position, so you may not be comfortable retorting with those difficult questions regarding your care. And patients are sometimes reluctant to get second opinions because there's a sense that if I'm getting a second opinion, it may be a betrayal to my physician, which is not the case. You should go and get your second opinion so that you're comfortable with the treatment plan that's being offered to you.
I can address it from the obstetrics side. The maternal mortality rate in the United States has increased while around the world it's been decreasing. Especially for Black women, the maternal mortality rate is about 3 times higher, depending on what region you are in. And you used to think that a lot of that was due to socioeconomic status. However, when you take out that factor, the Black maternal mortality rate is still higher. In college-educated Black women, the maternal mortality rate is 5 times higher. And so even when you take out education as a confounding factor, it's still very inappropriate. And a significant reason why that happens is implicit bias, are the assumptions, are that Black women generally feel not listened to, especially when it comes to pain. And I think some of that is representation. Some of it is that the doctors don't see themselves in the patients, and some of the patients don't see themselves in the doctors, and so the communication is not great.
And I can just add from an administrative side, we often get, so let me just back up and say that our patient demographic is, the majority of our patients are Hispanic and Black. And so our patient complaints are normally, the provider just assumed I had drug-seeking behaviors because I said I had pain, and they won't prescribe anything. Or, the provider rushed me or refused to get a translator. There are just these assumptions that are made about patients based on what they look like, whether it's their skin color, their gender, the clothes that they wear. And I'm finding as an administrator, and, you know, before I became the CEO, I was a compliance officer at my job, that if you grew up, if you're a provider or, you know, even an administrator who grew up with certain stereotypes or opinions of a particular racial or ethnic group, that carries over into your everyday work, whether you know it or not, whether it's intentional or unintentional. And I can give you an example. A quick example is a colleague of mine who I've been working with for a very long time as a white male. We were talking about something and he made this comment. I guess he felt comfortable enough to make it, that he just assumed that because I was Black and another colleague were Black, that we understood each other, or we knew each other, or had like common opinions. And I said, why? Because we're Black? And he said, yes. And that was just a belief that he grew up having. And so because he grew up with that belief, it kind of dictated how he interacted with other Black people in the office. And that's a very mild example, but it just goes a long way to show that those things that have been ingrained in us since we were children, they manifest themselves some way. And if you're a provider, a physician, it manifests in your everyday interactions with your patients. And it's something that we have to be aware of.
I'm gonna jump right off of this question and ask another question. What would you say to other health professionals, even people in this call that aren't even healthcare professionals? How would you tell them to acknowledge and work on such implicit biases? What are the ways in which people take into consideration those preconceived notions that they have against other groups of people, and remember and think about those things before they take action?
I can start. You know, the first thing is to acknowledge that everybody has implicit bias, and the whole point of it being implicit is that you don't really realize that you have it, you know, which is why I think increasing diversity in medicine and representation is so important, because as you work with other health professionals, they ask you their opinions. They may run something about a patient by you, and you may have a different opinion just based on your background, whatever that may be. And there's a huge diversity of backgrounds. And so when you begin to examine that and begin to talk about your individual experiences, the implicit bias can become a conscious bias, which can be addressed.
I would agree with Dr. Mold that the first step is really acknowledging that we all have implicit bias, and really to take the shame away from, you know, admitting that you do, and then you can go into an action mode. Is that what other things can I do when I engage with my patients to make sure that the implicit bias that I have, that this isn't going to be a part of the exchange, and be willing to see yourselves in your patient's shoes. We all have different experiences. We're all coming from different angles. And sometimes you have to take a step back and be humbled by those experiences. And I can tell you, I had, you know, many encounters. One of the most memorable patient experience I had was with a young woman who was diagnosed with breast cancer. And I had called her multiple times to come in to have a discussion about her newly diagnosed breast cancer and the surgical intervention that was warranted. Finally, I got a hold of her one day. This is months after her initial diagnosis. And she said, okay, well, I can come in at about 5 o'clock. Our office closes traditionally about 4:30 is when we're winding down. So I waited for her. She was a little bit late coming in for the appointment, and she sat down, we spoke. And within about 15 minutes or so, or half an hour, she was ready, you know, she was fidgeting, she was ready to exit and end the exchange. We hadn't even been able to schedule her surgery. And finally, you know, on my end, I'm thinking, my goodness, it's been months. I am here, you know, literally the office is closed. It's just you and I, just because I feel so vested as a woman of color with you to try to get this done. And then she looks at me and she said, Dr. Lawrence, the reason I need to leave is because I need to get to the pantry, because that's how I get food for my 2 sons for the evening. So, and she was actually late because the bus that she takes from work to the office was delayed. So it wasn't intentional. And she didn't feel comfortable that she has enough time or PTO hours to take a day off from her employer. She didn't want to risk losing her job. So here I am, a middle-class woman of color, and here's somebody in front of me who almost slipped through my thumb because I was thinking this is an issue of non-compliance. She really didn't want to get her care done, when in fact there were several other factors that were impeding her ability to get the care that she needed. And once I was able to really, open my eyes and realize what was going on, then I was able to help to plug her in with the necessary resources that she needed, which included a letter to her employer so that she could have the time off. Our social worker was able to be put in contact with her to see what programs and services we can plug her into. So those are the experiences that I often share with my peers, is that sometimes you have those bias, those implicit bias, and you mean no harm, but we have to acknowledge that the data that's available is objective, and there are disparities, inequities in terms of the treatment that's being rolled out to our patients.
I think that's a really great example, and I was just going to say the thing that I would say that I appreciate that your patient shared with you, and I often think of, or I make the assumption when I'm working with someone that I don't know the whole story. Right. And I think too many times we're moving through our day to day, and I see this all the time in workplaces. I work a lot with organizations, and I help them on their diversity, equity, and inclusion journeys. And, a manager will say, well, this person's always late. This person does this. And I often have to say, have you asked why? Right? So it's being willing to just stop and not assume that we know, that we understand the person that's standing in front of us, and that we understand their struggle, we understand their journey, and we understand what it takes for them to get into the office every day. And really pause and do that. And I feel the similar way with healthcare. I appreciate that Corinne said that she sought out a second opinion and got another healthcare provider, because what I see in our community, in Black and Brown communities, is we just trust whatever the doctor says. Like, we don't take the time and say, you know what, our health matters enough to go ask somebody else. And I get it, like there might be time issues, like I cannot take another day off to go ask somebody else, but it's your life and it's your health. And it is so important to just stop and say, you know what, I'm going to take the time. I'm going to do what I need to do to make sure that I'm taking care of me, or even our family members. I think about, my own child and her own, navigating her health issues and making sure that I was an advocate for her before she was able to be an advocate for herself. So I think that's I appreciate, Corinne, that you went out there and figured it out for yourself and wouldn't let up and made it, kept going on. And I think we need to, that's an awesome example of what we all should be doing.
Thank you. I just wanted to add two quick things. The first thing is, again, it is true, everyone has implicit bias. So yes, even in the Black and Brown community, a quick way to understand, and this is like really like breaking it down, a quick way to understand implicit bias is, if I said the word peanut butter, for most people, if I said, what's the first word that you think of? If I said peanut butter, for most people, if you thought jelly or jam or chocolate or candy, that's almost kind of how implicit bias works. You have like this preconceived notion. So when you automatically hear something like a Black woman, racism, but also implicit bias might say she's poor, she's a single mom. If I said a white Republican, again, as a Black woman, my implicit bias is racist as hell. Maybe far from it, but that's a quick understanding of how implicit bias works for those who are just trying to understand, well, if I'm Black or if I'm brown, I can't really have implicit bias. And the truth is you can. The other thing I want to say is that one of the things that I have MS, and so I my memory is horrible. So I'm in speech therapy to work with that. And I'm so upset that I didn't work on adding this to the 2 bills of declaring racism a public health crisis. SB1 and HB 6662 is one of the things as a result of going through all I went through with all of my, I have MS, I have a non-cancerous brain tumor, and I have chronic migraines. And by chronic migraines, I have migraines 30 days out of every month. So every day I have a migraine. I either get the aura or I get the full-blown pain. And so because of all of my health issues, and because of my mental health issues, I have really had to be an advocate for myself. And as an activist, one of the things that I am really trying to do is to empower people. And one of the things I really wish I could have added to this bill is that we need to hire, the same way we have social workers or case managers in hospitals. I think that a healthcare advocate should be stationed in every single doctor's office, whether it's private practice, hospital, mental health place. So if a patient comes in and feels like they are not being heard by their physician, they should immediately be able to say, I would like to have the health advocate join me in this office. Or maybe when they first come in and they make the appointment, they may say, I would like to bring a health advocate, or I would like to have the health advocate present. I think the health advocate will be able to, they are in a position where they are solely there for the patient. And so if a patient is saying, I want X, Y, and Z, and the doctor replies, okay, you're going to get ABC, the health advocate says, wait a minute, she said she wanted X, Y, Z. So I want you to now document in the chart that she asked for X, Y, Z, and you are going to give her ABC. Because a lot of people, for whether it's language barriers, whether it has to do with their religion or whatever, they may not feel comfortable advocating for myself. I didn't feel comfortable advocating for myself for a very long time. And it's because of where I'm in life at now that I have not had a choice. So those are the 2 things I wanted to add to implicit bias.
Thank you so much, Ms. Prescott, for sharing that. You actually have a question addressed to you. And this question said, I'm so sorry that you had to endure all this trauma. How would you help other patients navigate tough diagnosis and make sure that you have a provider that sees you as a person and not just a patient? And you kind of did just touch up on this, but this is your question and answer.
So if you are personally experiencing this, email me, powerupmanchester@gmail.com. We offer basic case management services. And so if you are personally dealing with that and you need help with that, please email us and let me know that this is where you heard this at. The next thing I would say is that you are the patient. You are the customer, essentially. If you are going to go into Walmart, Target, wherever, and you are going to demand a certain level of customer service, take that same energy, you know how they say, keep that same energy, take that same energy and apply it when you go into the doctor's office. When I got diagnosed with MS, white male doctor, I'm not from Connecticut, I was living in Philly, I was at Temple University Hospital, I'm laying there, and I couldn't move my arms or legs. And he sits down and he says, so you have MS, right? And I'm like, I didn't even know what it was. And I'm like, no. He's like, well, yeah, you got MS. Okay. I had to learn. That was 2013. It's 2021. It took a long time. So first of all, be patient with yourself. Be patient with it. Be comfortable with being uncomfortable. Be okay with not being okay. And if you are Black or brown and you get something like a diagnosis like this, get a Black or brown therapist. I have a Black female therapist. I didn't do my first time ever. I didn't realize how big of a difference it was. I've seen therapists all my life. They were always white. I didn't realize how big of a difference that would make. So I would say be patient with yourself. Do not be afraid to speak up for yourself, and take the same energy that you apply if you were being mistreated in a restaurant or a grocery store and you were asked to speak with the manager. Take that same energy into the doctor's office to demand that you get the care that you deserve. I hope that answered your question.
Thank you so much for answering that question from our audience. And if anybody would like to add to that, I'm opening this question up as well.
I was just going to add that as a physician, I think the exchange between a patient and physician should be one that's rooted in mutual respect and understanding. If you are presenting with a problem, the physician is the expert in terms of the wealth of knowledge. And bring your questions, bring your tough questions, and ensure that they're answered. But I have also had experiences with patients where they come in and they sort of know exactly what they want, but that may not necessarily be the right treatment for the patient. And I have to find a polite way to explain to them that while this is an option that's on the table, in your particular case, because no two patients are always going to be exactly the same, this is not the best treatment option. And I do this quite often when it comes to breast cancer. The patients will come in, they'll share stories of a friend or somebody else who've had a breast cancer diagnosis and the way they were treated, and this is what I want, and this is not what I want. So it's a slightly different experience and exchange. And, I have to sit down and explain to them that we treat breast cancer based on genomics and the biology of the tumor. So while your friend may have had this particular treatment, in your case, this may not be applicable. So I would say enter those spaces with the understanding that this should be an exchange that is rooted in mutual respect and understanding. And if you're not able to establish rapport and feel valued and listened to in that experience, then I think it's very much okay and acceptable for you to get a second opinion, because you want to be with somebody who you trust and you know that they have your best interest at hand at all times and along the entire decision-making tree.
I would just reiterate that, every single decision that a physician makes should be based on something. We should be able to explain why we are doing what we are doing, and even if your care is individualized. And if you feel like you're not getting the answers, I would encourage everyone to tell their provider that they feel like they don't understand why this is the treatment, or why that's the decision being made, or why this is the evaluation, because whoever you are seeing should absolutely be able to explain that to you. They did it for a reason.
Thank you all for expanding on that and sharing. So the next question that I want to go to is actually one question that I wrote about in a couple of different areas, especially in the college process. This is a question that I was always thinking about. And Dr. Mold, you kind of touched upon this, but the question that I have is, well, it reads, complications during pregnancy occur at similar rates for Black and white women, yet death and morbidity rates are higher among Black women. Black mothers die even when they are young, fit, and educated. This opens a whole new door of questioning as to why healthy Black women are dying. And so I hope you can get the question out of that. Pretty much is, why are healthy young women dying? And not only in terms of maternal mortality, but things like breast cancer, things like generational trauma. And I know that you guys are all experts in different areas. So in your own expert knowledge, why are Black women, healthy Black women, dying?
Very complex question, but it's a very important question. The first thing to think about is, or first always, is to acknowledge that that's happening and the situation is getting worse. I would say when it comes to serious complications, especially preventable ones, actually Black women have a significantly higher rate of that happening to them. Part of it is what was touched upon before, which is that most studies in medicine are based upon our white counterparts. Black women or the Black population are not always the center of studies. And so when you think about a little bit about regions, genetics, the things that are more common in our backgrounds are not fully studied. And so there's that. The other part is implicit bias plays a really big part in it. I think, you know, it's a question that there needs to be a lot more research into the reasons why this is happening. Most recently, so every time there's a complication or especially maternal death at a hospital, it's always reviewed. And really just in the last few years, part of the data that's being kept or discussed is what does race have to do with this? You know, rather than just saying like, this is a maternal death, let's review this case. Now, part of the conversation includes this was a maternal death or this was a maternal complication and this woman was Black. What did that have to do with it? What is it about this individual that allowed this to happen? About 60% of the deaths that happen, not just in Black women, but in women overall, maternal deaths are believed to be preventable. So there has to be particular studies that are done about us. There has to be protocols. There has to be adherence to those protocols. There has to be appropriate reporting, you know, and then we also have to take a look at ourselves and say, what is it about us personally that we are allowing this to happen to those patients? I don't know if that, sorry, have a.
Oh, that was perfect. Thank you.
Okay.
Thank you for that response. And I'll open this
So
up.
I would like, I would love to just add something there. I mean, you know, I've had my own share of health issues that I've navigated, you know, especially like later here in my life, as my body is transitioning. And I was shocked to find that, and I know most people won't be shocked, but I was, that money is behind so much of what happens, and right, and it's like capitalism, you know, run amok. Because right when I was having an issue, and right, I was having an issue with, and this is very common, especially in the Black community, you know, women's histories with fibroids and, you know, other gynecological issues that causes lots and lots of bleeding. And I was literally bleeding so much that I had to be transfused like twice in a month, right? Blood transfusions, right? That's not something you go and like hook up and you get blood for a couple of hours and you go home. It's like an overnight in the hospital process and procedure. And the reason why it was happening is because my doctor was not monitoring me, knowing my condition and knowing what was happening, wasn't monitoring me in any kind of level. It was just like, well, you know, if you're not feeling good, call me in 3 days or call me in a week or a month. And then when I said, you know, I really want to have a procedure that's not an invasive procedure, she basically said, well, your only options are, you know, this and this, which were two totally invasive surgical procedures. And a friend said to me, have you tried this other procedure that's really not invasive, you know, blah, blah, blah. And I went back to my doctor and said, why aren't you recommending this procedure for me? And she said, because I can't do that surgery. Like, she told me that. You have to go to an interventional radiologist. So I can't make money off of it. So I'm not going to recommend it for you, basically was her answer to me. And I said, so you would just rather, you know, do some surgery that I don't want to have just to not refer me to another doctor. It was beyond my understanding of care. And so in my brain, being very naive, I was sort of like, what happened to this Hippocratic oath that you take? What happens to actually treating me like the patient and the customer that's asking for a specific kind of care? And so it was just very interesting. That whole journey sort of put me in a place that said, I know so many other women who have been in a similar place that opted for this major surgery that they didn't need to have. right? If their doctor just told them and was honest with them about their options, but doctors are focused on that dollar, right? Focused on the money, what's going to be billable, what's going to, make it better for themselves. And I'm not speaking to you ladies. I know you wouldn't do that, but right, there are people that are out there not necessarily caring about the person's health and more thinking about how am I going to bill for this? And so I think that's another angle that we have to think about in putting ourselves first and pushing and asking the question, and then being willing to, like I had to, because basically my doctor said, if that's what you want, go find it. That's exactly what she said to me. If that's what you want to do, go find the doctor. Here's a suggestion at this hospital, track it down, was basically what she said. Was kind of like angry that, that I wanted another kind of care. So I think that's just an important piece to continue to be an advocate for yourself and not take, something else as the answer if that's not what you desire. So I think that's just an important piece.
I would just add, in terms of capitalism as well, is there are plans and provisions in place through our insurance companies that help to dictate the care that a woman gets. Within Connecticut, I can tell you the average deductible plan, it's very high. And there are several patients who are hesitant to seek medical care because of the risk of financial toxicity. I've had patients who've come in and their screening mammogram is covered by their insurance. But if an abnormality is found and you need diagnostic images or you need a biopsy to clinch the actual diagnosis, those costs go towards your deductible. And immediately the red flags go up. Can I afford this? It's a couple $100. Not everybody has a couple $100, or the average cost of a biopsy is $2,000. And the biopsy is needed to clinch a diagnosis. So if your deductible is $2,000-$3,000, you're thinking to yourself, all right, I don't have that kind of money. So that serves as a deterrent. I know recently, I think it's this year, we're able to, Connecticut passed a state law that diagnostic images will be covered by your insurance and they won't go towards your deductible. But when you think about the structure of various insurance plan, is that they are not necessarily designed to take into consideration some of the social determinant of health, which has to do with the financial piece of it, that if you're within a certain income bracket and you're making a certain amount of money, this is a plan that your employer offers. Where do you get that money from to even clinch your diagnosis? So if you don't get the biopsy, you don't clinch your diagnosis, these are the patients that we see much later on, a few years later, that now have distant disease. And now you're treating them for metastatic breast cancer. It costs the system even more to treat for distant disease than to treat a woman that comes in with a very small early breast cancer that's very manageable. So there are built-in system issues that we all have to work collaboratively when we see these barriers to care to try to change and to help with.
If I can add to this, the intersectionality between racism, classism, capitalism, and healthcare. She read my bio. I'm very transparent. I'm open book. So I lost my job in 2018 because I had a flare-up that lasted me about 8 or 9 months. And then that's when I was diagnosed with a brain tumor. And so I've been fighting for disability ever since. And so I now have Husky. And when we talk about, doctors not being able to make money off of it, one of the things that prohibit poor Black folk like me from getting better or having access to better healthcare is simply having Husky. And what I mean is, when I didn't like the neurologist I had, I called several neurologists. And one of the ways a lot of these white doctors and doctors' offices that are primarily white get away with not seeing poor people and Black and brown people is by saying the following words that I've heard over and over and over. We do accept Husky, but we're not taking any new Husky patients at this time. So or they'll say, yes, we are accepting new patients, but we are not accepting new Husky patients. So then that limits who I have access to. And so if I'm not stripped simply because of the type of insurance, because there's this implicit bias that if you have this type of insurance, you must be this type of person. And so I have not been able to really see the providers that I really want to see. There's a primary care doctor, a Black woman that I really want to get into. But unfortunately, because I have Husky, I can't. And so there's other stipulations that go along with that. And so I understand that. But for a lot of people like myself, when we look at why Black and brown people are dying from things like COVID or the maternal mortality rate, things like that, a lot of that also, I believe personally, has to do with the fact that we are only able to see certain providers, and we aren't able sometimes to get second or third opinions simply because of us having Medicare or Medicaid.
Thank you all so much for sharing and elaborating on that question as well, and especially on expanding on socioeconomic status, which I know is another really important factor. We have about 15 minutes, so I have about 3-ish more questions that I want to ask you guys in those 15 minutes. My first one is, can any of you guys just elaborate and talk on the importance of Black mental health and why it's so important, but it's rarely ever discussed?
I will say I'm a preacher's kid. My father's a pastor, my mother's a minister, my sister's a minister. Coming from growing up, my mother grew up in a very Black Baptist environment. It was taboo in their household. My parents have masters in social work, and so they broke that generational curse. But for them, it was, the saying, "I'm too blessed to be stressed." It was pray about it, fast and pray. And my motto is, if you believe in God, if you believe in Jesus, Allah, he created all people, which means he also created modern medicine. He created doctors. And so, yes, I can fast and pray, but I can also go get some therapy. And I can also, get a referral to a psychiatrist if I do feel like I need meds, and there's no shame in that. And so I think that, as an activist, that is why I'm also so transparent, because I want to try to remove the shame and the embarrassment of having to have these conversations about mental health. Depression is real, anxiety is real, PTSD is real, trauma is real, and sometimes prayer is not all you need. Sometimes, laying of the hands and some, oil on your forehead is not all you need. Sometimes you need to sit down with a therapist who may specialize in EMDR, or, sit down with your daughters or your son or your husband with a family and marriage counselor and process what you have gone through. In addition, while you're going to Bible study, or while you're going to the mosque, or you're going to, wherever you go to worship, or going to your own altar, it is, I think we are getting in a better place. Thank you to people like, young folk like Mercy, and thank you to, social media and Black women influencers and YouTubers being more open and honest, and brown women sharing themselves and opening themselves up and being vulnerable to have these kind of conversations. And for, panels like this, where we can be in a safe space, where we can ask the questions and we can open up and talk about some of these very difficult topics like mental health.
Period. Thank you so much. That was perfectly said. So I'm going to move on to the next question. I have about 2 more questions left. And this one, again, is open to everyone. But why should racism be declared a public health crisis? And how can everybody in this call help with that fight and that struggle?
I would say, I mean, there's no question about it. It is a public health crisis. And as I said before, the data is real, the facts are there, and something needs to change, something needs to be done about it. I think we need all hands on deck in order to bring about meaningful change. I think there's a lot of conversation about declaring racism as a public health issue, but in terms of tangible efforts that are being made, I am still hoping and waiting and looking for ways in which I can see everybody getting involved, because it's going to take an entire system upended in order for us to get to where we need to be. But absolutely, it should be it's long overdue in terms of declaring it as a public health crisis.
And I'll just add, I know I've been pretty quiet, but you ladies are holding it down. I have been very vocal about this.
Nichelle, why don't you try and turn off your camera?
Racism as a public health crisis. While it is a good first step because you can't fix anything unless you acknowledge that it's broken, it can't stop there. And so if the intent, can you hear me better now?
Yep, we could hear you better. Yep.
I'm not sure if you all can hear me.
We can hear you better with your camera
Okay,
on.
thank you. Okay, so it's a good first step. It can't stop there. And if the intent is to declare racism as a public health crisis to pacify Black and brown people, that's just not sufficient. We need more action. We need to see more change, tangible change, and we need the legislature to hold people accountable for that change. And as Black and brown communities, we need to hold our legislators accountable much during this crisis, during this pandemic that has left me at a place where I can no longer be silent. I can no longer just go with the status quo. I will no longer just vote on one ticket because I'm registered with a certain party. We need to hold people accountable. We need people in office who will hold this task force that will come about as a result of this legislation accountable. And we need to see some tangible results. And if the people that we have elected to put in office can't do that, can't assure it, then we need to do that. We need to make that change, and we need to change the people who are in office.
If I can quickly add to that, she said it best, you cannot cure what you cannot diagnose. And so we cannot make pleas or make demands about having certain funds and resources and services assigned to the Black and brown community if we cannot even acknowledge that racism even exists. And so the declaration is a start, but there needs to be some real power behind that. We need some real conversations and committees put together to acknowledge the redlining, to acknowledge, the housing insecurity, food insecurity. We have to acknowledge that Black and brown people do not have access to quality health care. We have to acknowledge that that kids in New Britain or Hartford are not getting the same funding as kids in Farmington or Fairfield. In order to be able to do that, we have to make this declaration. It is very, very, very important that each and every constituent, each and every person who can hear and watch this, that if you are eligible to vote, that you do vote. If you are eligible and not registered to vote, get registered to vote. If you are eligible and you're registered and you are voting, the next step for you is to start seeking office, especially if you're Black and brown. But then again, all skin folk ain't kinfolk. So, so again, I'm not just voting for somebody just because they're Black, and I'm not voting for somebody just because they're Democrat. I got to see what you stand behind. And so one of the things that you can do currently right now is to email your governor, email Ned Lamont. as much as you can every day and say, you need to make this declaration. And then you need to put together a committee. And then we need to have mandates. We need to have mandates on every single system under systemic racism to collect data. And there needs to be some incentives for the towns and the municipalities that do it. And if they don't collect the data, then we need to say that the government needs to say, you know, we're going to withhold certain funding until you get us the data that we have said that you are supposed to get us. The data is already there. But now we need to go ahead and further collect more data. But the data is there enough right now for us to address this and for us to make this declaration. The same way that we were able to get, some of us, not me, because I'm still waiting on that STEMI, be able to get them stimulus checks, the same way we were able to make, for some areas, make the vaccinations more equitable. The way we were able to get, you know, the PPP loans and those things was because they had to declare COVID a health crisis. Once they did that, then they were able to assign certain resources and fundings to address the health crisis. And look, in a year's time, they have a vaccine. Racism as a pandemic been around for 500-600 years. COVID been around for what, a year? So they were able to get the information that needed to be done because they made that declaration. And so the same thing needs to happen with racism.
I think we might have lost.
Did we lose you, Mercy? Nope, you're, she's muted. Mercy, if you're talking, you're muted. Okay, well, we are almost at the end, so I do want to open it up if there are any last minute questions. Actually, before I do that, I would love to open it up to our panelists. If there are any action items, you know, we did talk about the importance of voting and getting out there and you know, being active in the change that you would like to see. Are there any parting thoughts that we as a community can do in order to move us in the right direction, each and every person?
I would say, I was just going to say, don't wait. Don't wait for someone to come educate you. Educate yourself. I tell my daughter, I tell young people, anybody that's under 30, stop asking me questions and go to the internet. You have more information at your fingertips to find out whatever you want to know. Be proactive about it. Find out how to become an anti-racist. Don't ask Black people. Go figure it out. There's lots and lots and lots of resources. And be proactive. I want to applaud all the people that have joined in the call today to hear this conversation, because that's showing that you are being proactive. Keep doing that. I often think about if somebody that you loved had an illness that you never heard of before, would you sit and wait for somebody to come tell you what was going on with that person, what should happen next? Nope, that's not what you would do. You would get on the internet. You would call every doctor that you know, even doctors that aren't even related to the illness that your loved one has. You talk to everybody you know, you get as much information, you'd buy books, you do all the things. And we want you to think about your journey around race equity, around inclusion that way. We want you to treat it that way. So that's the one piece I would say, be proactive, go after it, figure it out, just like you would anything else you were really, really interested in your life. So that would be my parting coming from Recenter. That would be my parting suggestion.
I would add to that a couple things. For our white folk, who I also call co-conspirators in this fight, I would add to that, learn about and educate yourself on micro reparations. If you are white, whether you are racist or anti-racist, you have benefited from your privilege. And micro reparations is one way that you can atone for your advancements in life simply because of your privilege. The second thing that I would add is that if there is a patient similar to the patient that Dr. Lawrence spoke about, this woman who missed the bus or the bus was late and she had to, leave early to get to the pantry, again, reach out to Power Up, because I need Black and brown women to get to the doctor. And so if taking too many buses to get that diagnosis, to meet up with your doctor because they have a report for you, contact us. We will get you an Uber gift card to make sure you can skip the bus. If we have a pantry, if you are trying to figure out, because pantries close and open, Power Pantry is 24 hours. So therefore you cannot get into it, but you can reach out to us and say, hey, yes, I just got off of the third shift and my kids have no food and it's 7 a.m. We will get somebody to your home. So reach out to Power Up Manchester, powerupmanchester.org, powerupmanchester@gmail.com. And please reach out to your doctors, see your doctors, stay up to date with your well visits. And if things like money or transportation or food are barriers, that's what grassroots organizations like Power Up are here for, to kind of fill in those gaps. So that way these medical professionals can be able to keep you whole and healthy so you can take care of yourself first and your family. And reach out to your governors and state elected officials and tell them to make this declaration and put some teeth behind it.
Hey y'all, I'm back. Sorry. I know that we're completely out of time, but I wanted to thank all of our panelists and everyone that was here for sharing your experiences and for educating everyone listening, and for giving us some next steps. And I think that we wanted to do a couple more giveaways. So I think we have 3 more.
We have 2 more, Mercy.
We have 2 more. So we're gonna pull up our wheel and spin it 2 more times, and then we're gonna say goodbye to our panelists. Congrats to Loomis. Okay, we have 1 more. Congrats, Ileana. You also won another one of our giveaway items, and just be on the lookout for someone reaching out to you about the giveaways from this discussion. I want to thank you all once again for joining us, and I want to give a sincere thank you to all of our panelists. You guys' insights and knowledge is genuinely astonishing, and I know that I've gained so much from this conversation today, and I know everyone listening has as well. So thank you, thank you, thank you. And I encourage everyone listening to take some action steps, whether they're ones that you've heard here today or ones you were thinking about taking prior to this. I strongly encourage you to find a way in which you can make active change in whichever communities you are in. That's it from me. Thank you all once again, and have a great night.